So my goal is to talk about other bleeding and clotting issues, and hopefully throughout this presentation, I'll be touching on something that is important to you as well. And if there are other things that you have questions about, I'm happy to entertain those, because obviously we take care of quite a diverse group of patients in the type of things that we take care of. So we're going to do like a high level view, talk about at the beginning some bleeding disorders, and then we'll close out talking about the other side of some clotting issues as well. And like Dr. Tarantino said, if you have questions or comments throughout, I'm happy to entertain those. I'm going to try to fit it all in about 30 minutes, and certainly is a lot to go over. So we'll kind of take big picture stuff. So also when I'm talking about hemophilia and I'm talking about bleeding disorders, if you have another type of bleeding disorder, I want you also to think about, and there'll be a slide on this, some of the things I'm talking about, we're actually thinking about using in other rare bleeding disorders. There may be some of the therapies we're talking about that are not just related to a specific coagulation disorder like hemophilia. But just to kind of level set, hemophilia most commonly is deficiency in factor 8 or 9. Usually affects males more so. It's X-linked recessive, and females are carriers. However, that being said, there's a lot more women now that have levels low enough that they should be considered to have mild hemophilia. And so we actually have many women now in clinic, and families are taken care of for quite a while, that moms of children with hemophilia actually have symptoms enough that we call them mild hemophilia, and we treat them as well. A lot of times people with hemophilia bleed into muscles and joints. There's different levels of severity there. And the overall goal is to try to prevent bleeding, right? We want people to live, whatever your bleeding disorder is, to live a life free of having bleeding complications. And that's our goal. You can see there the half-life, or how long the factors tend to last in the body when that's a regular non-modified protein. And kind of the mainstay of therapy for years has been to infuse factor, if you have a severe bleeding disorder, to help prevent bleeding, so that you can do the activities that you want to do safely. So there's really been a changing treatment landscape. And again, this is hemophilia as a model, but this is really what we're looking for in multiple different disorders. In hemophilia specifically, there was kind of pre-replacement therapy. So in the old days, meaning like in the 1950s, and 60s, there really was only supportive care. Patients, if they had a bleeding event, would have to go to the hospital. A lot of times would have to get whole blood. I've shared with some of you in the room, I myself have severe hemophilia. So my uncles had hemophilia, and they were in the hospital a lot, just getting whole blood transfusions, because the doctors at that time didn't know how to treat their specific bleeding disorder. This would lead to chronic pain and bleeding into joints, and have a pretty high mortality. A lot of people with severe bleeding disorders died prior to the 1990s. Then we moved into replacement therapy. There's on-demand or prophylaxis. Prophylaxis is a word meaning treating even when you're not having bleeding, or treating to prevent something, okay? So we would, now that's really the standard of care for people that have bleeding disorders, to try to prevent bleeding. And there was really this transition to home-based therapy that started to happen in the 1980s and 90s, and has really expanded in recent years. And now, you know, there's a much lower mortality for people who have bleeding disorders, specifically hemophilia. It's now approached the normal life expectancy of people who don't have a bleeding disorder. So I actually am on a task force nationally for what's called the Medical and Scientific Advisory Council for the National Bleeding Disorder Foundation. And I'm on a group looking at what we call geriatric guidelines for people with hemophilia, meaning that people with hemophilia are living old enough now that we need to figure out what's the best care for people that are in older age who have a severe bleeding disorder, which is a really exciting thing. You know, 20 years ago, we weren't able to say that. And now we're actually having a group task force to try to see, you know, what do we do if people get advanced heart disease? What if they need procedures? What if they have other complications of their bone health, musculoskeletal health, mobility, all those things we're looking at. Then we move into non-replacement therapy. So there's been some innovation talking about things that are not factor, that still help your body make clot well. And those are some of the things that may have some broader use beyond hemophilia. And then ultimately gene therapy. So there are a few licensed products for both hemophilia A, or factor 8 deficiency, hemophilia B, or factor 9 deficiency, that will touch on as well. So it's a really exciting time. So to kind of give a patient perspective of hemophilia treatment in the 1950s and 70s, really the idea was treat my bleeds and keep me out of the hospital. People just wanted to be home. They knew they were going to have problems. They knew they were going to have joint disease, but they wanted to stay out of the hospital. In the 80s and 90s, which is the era when I kind of entered the scene, was all about safety. Make my factor safe, keep me out of the ER, prevent bleeds. This was the era where we lost a lot of the population, really almost a generation of people with hemophilia and severe bleeding disorders because of HIV, because a lot of the blood products were tainted. And there's some really good documentaries out there now honoring that legacy. If people are interested, I can talk to you after about those if you want to view for your viewing pleasure. And then now the 2000s beyond is really all about personalization, making factor last longer, lower treatment burden, better quality of life. So when we get these, and this is a paradigm that we're using in really all types of bleeding, clotting disorders, is once we're able to treat the underlying problem, we really need to focus on then how do we have patients have an optimal life, do the things that they want to do with the lowest treatment burden and the best outcomes. And then ultimately we're looking for a cure in hemophilia and other things. Persistent concern for people with bleeding disorders, especially hemophilia, don't let me get an inhibitor. That's an antibody that neutralizes the factor product if you're taking that. A little bit different than ITP, but the same thought that it's an antibody that's doing something it's not supposed to do. So looking at hemophilia specifically, but also, other factor disorders like factor 13 deficiency or fibrinogen problems. Cryoprecipitate was actually one of the first treatments that was available in the 1960s, developed by a physician there pictured on the upper right, Judith Graham Poole in 1964. And you, for the first time with the discovery of cryoprecipitate, factor VIII levels could approach 30%. So this meant that patients could actually at home give themselves a blood transfusion component and then prevent or treat some of their bleeding events. And cryoprecipitate is made kind of how it sounds. It's the part of your blood, if it gets cold, if things precipitate out, factor VIII being one of those things, and other proteins like fibrinogen, factor 13 as well, and can be used in that regard. So suddenly bleeds were stopped more quickly. Every local blood bank could offer effective treatment for hemophilia A in particular, and life expectancy increased. And this is kind of one of the early historical treatments that was used that really was a step forward in trying to treat people with hemophilia A specifically. So then there was this boom in developing factor concentrates. So cryoprecipitate, like other blood products, if you're familiar in the hospital, like if you get a blood transfusion, is a bag, it comes, have to have an IV, drips in. It's not really conducive to easy home therapy. So people found out how to isolate, make a very highly purified powder that could be reconstituted with sterile water at home, and then mixed up, and patients could stick themselves, infuse themselves at home. It was actually in this era, in the 80s and early 90s, when the blood supply was tainted by hepatitis B and C and HIV, and we lost a lot of the population, unfortunately. But then the community responded, and they found different ways to inactivate viruses, doing things like dry heating and pasteurization, some solvent detergent treatment, this immunoaffinity chromatography, which is a fancy way of saying a column that helps to separate out and purify some of the proteins that are in there. And really that has helped transform to where any of the plasma-derived products, which we also use for things like von Willebrand disease, since the early 90s, there's not been any reports of any type of viral products that are getting to humans and causing disease. So that's really been a good success story. And ultimately, really in a large part from the patient community demanding for safe products was the development of recombinant factor products, which is really the development of making the proteins pure in the lab so that it's not coming from blood donors, and so that we actually have, in theory, a perfectly pure product that's made in the lab that's completely safe. And so that premise has been used for hemophilia and really for the other innovation that's spurring on other treatment of bleeding disorders using that type of technology. So actually, this has been used really for over the past couple decades. And the recombinant factor concentrates are made by multiple generations of products. And actually now there's so much innovation that even the word generation of products is starting to get a little bit dated because the newer molecules are so new and unique, they don't really necessarily fit in any particular category. So the first generation was really if the proteins had some animal or human plasma-derived proteins were still in the final product that was infused in the patient. And then in the second and third generations, basically move forward to where in the products on the market today, there's no animal or human proteins in the final product. So patients are getting, in theory, completely pure, no risk for any disease transmission. And you can see now, it's really interesting, a whole nother talk in itself, is how these recombinant DNA technology uses Chinese hamster ovary, baby hamster kidney, and human embryonic kidney cells to make these products. And this has really kind of become the standard of care in the US and other developed countries for treating bleeding events if you have hemophilia. So then it moved on to, prophylaxis became more readily available and could do treatments at home. So some of the emerging therapies that have happened are some ways to extend the half-life or basically make the factors last longer in the body. There's been new approaches to how the protein is structured and how it's manufactured that can make the clotting factor last longer. Because if you think about it, sticking yourself a couple times a week with a needle and injecting a medicine can be a challenge, especially can be a challenge in some of our younger patients. Sometimes we have to do things like give them central lines or place a metaport where they are able to infuse factor more readily. And so, some of these technological advancements have been helpful in that regard, but there's still sticking a patient with a needle. There's some treatment issues there. And so that's really spurred on to some of the other therapies we'll talk about, like non-factor replacement therapies and ultimately gene therapy. And patients commonly ask, is there a pill in development for hemophilia treatment? And that's been looked at. We're still quite a ways away for anything like that. There's been some maybe advancements, but not enough to where the protein can actually get into the bloodstream well through the gastrointestinal tract. So unfortunately, we're still left with more intravenous or subcutaneous therapies in that regard. So specifically to factor VIII and IX, how do we make the factors last longer? There's a couple main ways it's been done. One is through what's called pegylation. And so PEG, or polyethylene glycol, is a non-reactive molecule. It's actually, if you've ever taken like Miralax or that type of stool softener, that's polyethylene glycol. But they found a way to stick tiny little amounts to the factor that helps shield it and protect it in circulation from being broken down. There's also fusion proteins that you can see the second diagram there, help to use a neonatal, what's called an FC, that actually helps to recycle the factor back into circulation. And then for factor VIII, specifically coupling or binding to von Willebrand factor with one particular product that we'll talk about in a few moments here. So there's different ways to try to make the protein last longer. So one of those newer factor products with that long name, efanesoctocog alpha, or EFA, people call it, prior to it being licensed. And this is on the market now. But it's a molecule that basically has taken factor VIII, which are those kind of darker bluish purple in the diagram, the A and C domains are factor VIII, and it's bound to von Willebrand factor, a fragment of von Willebrand factor that's made in the lab, with a few additional proteins surrounding it that basically help to shield the factor VIII from being broken down in the body. So if you have von Willebrand disease, or you've heard me talk about that and hemophilia, von Willebrand factor and factor VIII have to go hand in hand in the circulation. So they have to travel together. And part of the problem with some of the other earlier products in lasting longer is that the factor VIII molecule is bound to the patient's own von Willebrand factor. So with this EFA molecule, they're able to have that in circulation on its own so that the factor lasts longer in the body. So what's that mean? For the first time with hemophilia A, with a factor VIII medicine, the half-life is about 48 hours. So in the first slide, regular factor VIII is about 8 hours. So what this translates to is that people can infuse once a week instead of infusing with factor multiple times per week. And even in children, and actually this the paper came out just this last week in the New England Journal of Medicine, this molecule used for children, the half-life is about 40 hours. So meaning that most of the days of the week, factor levels can be in the normal range with a once-a-week infusion. And those factor levels are high enough that it can be protective for a lot of things. So this is for a lot of activities. So this is really, kind of a groundbreaking scientific advancement that's helping people with hemophilia A who are missing factor VIII. So I'm going to switch gears a little bit and talk about just some of the newer therapies for hemophilia. And actually, again, I want you to think about this not just for hemophilia itself, but also for potentially other bleeding disorders. So you can see, this is actually the complex coagulation cascade, and we're not going to go through all of it. But this is just to highlight all these different categories here are different mechanisms or ways that are being looked at to actually intervene in the coagulation cascade and help to stop bleeding. So some of these things, especially like here, the darker purple, the emicizumab or Mim8, these are molecules that are subcutaneous that you don't have to find a vein and start an IV and stick the patient to give factor, but it's subcutaneous, and that's a benefit to some of the patients. Other things here, the antithrombin knockdown or TFPI, these other molecules intervene at different places in the coagulation system to help make the blood clot a little bit better. So as I mentioned, some of these non-factor options, they're pretty much universally subcutaneous or stick under the skin. And it helps to replace some of the deficient clotting factors. And we'll talk about a few of those here. So one of them is emicizumab, which is a molecule that helps to promote clot generation or thrombin generation, the most important component of forming a blood clot. And basically, you can see here, that's factor VIII that usually takes factor IX and 10 and helps to make the blood clot. This molecule here, emicizumab, is an antibody that's given underneath the skin that helps to do the same thing. And it causes blood to clot kind of at a constant rate in the background. It lasts a lot longer. Patients can inject themselves once a week or even a few times per month or even once a month because the antibody lasts a long time. So you can imagine, again, someone that has a little kiddo that they're trying to infuse, you're saying give them a factor 2 or 3 times a week with an IV you have to stick at home or give it through your port. And now there's an antibody that you can give with a shot under the skin once a week or even less often. As you can imagine, with some of these things that are not factor, but using an antibody or a non-factor way, some of the early experience, if you combine the antibody with some other clotting factor medicine, could cause blood clots to happen. And obviously now we've learned more, and most patients that they avoid this combination do very well on emicizumab with low risk of having blood clots that you don't want to have. Another way that's being investigated that's currently in clinical trials is a molecule called fitusiran. So this molecule was developed on the premise that some people have clotting disorders that we're going to talk about here in a few minutes, and some people have bleeding disorders. One of those clotting disorders is called antithrombin deficiency, and antithrombin deficiency is actually a clotting disorder that people have a higher risk of forming blood clots. And so based on this premise, the thought is if patients have a clotting issue and a bleeding issue, if we can balance it out, potentially could we stop bleeding and prevent bleeds from happening. So this molecule is a small interfering RNA. So what that means is RNA is a process in the body that actually makes proteins. And so this is another underneath the skin injection that's given around once a month or even less often, once every couple months, that helps to stop the liver from making antithrombin to then try to balance out that bleed clot risk. Molecule's pretty good at reducing antithrombin up to 70 to almost 90% reduction. The issue that we are seeing in the clinical trials, and that makes this maybe not the best idea for a lot of patients, is that there's blood clots that are happening that we don't want to have happen. And as we talked about, people now are living longer with clotting or bleeding disorders and clotting disorders. And so if you can imagine, as we get older, we get things like high cholesterol, high blood pressure, things like that, obesity, other things that contribute to your clotting risk. And so you can imagine if we're normalizing the bleed clot risk, that we're going to see people have more blood clots from other causes as well. So this is something that we're watching very closely. Probably won't be used by lots of types of patients, but it's another option that could be used for any hemophilia and may also have other applications in other bleeding disorders as well. Another molecule that's actually been approved in Canada that will probably be getting approved here soon, concizumab, uses another pathway called tissue factor pathway inhibitor. So it actually is a molecule that does what's in the name. Tissue factor pathway inhibitor helps to prevent bringing factor 10 and factor 7 with tissue factor to make clot form. And the inhibitor actually inhibits this pathway. So it's an inhibitor of a natural inhibitor in the body, which then allows the body to make more thrombin, to make more clot happen. This is a daily injection underneath the skin. So some patients, if I just said there are some things you can do once a month or once a week or less often, and then now I'm saying this is something that you're going to be doing every day, maybe some patients will be interested in it. Certainly if they have one of those inhibitors or one of those molecules that neutralize this factor, this could be an option for them. Again, there are some patients that have had clots with this, but as we've learned more about the molecule in the clinical trials, there are some different mitigation strategies or prevention strategies to help prevent blood clots that we don't want from happening. I'm going to touch briefly on gene therapy. You may have heard it made, international news that gene therapy is available for hemophilia, both hemophilia A and hemophilia B. There's a couple different concepts for how to do gene therapy. One of them, which is what the products are on the market today, is taking a virus and putting adenovirus specifically, putting in the genetic material to tell the liver to make more of that factor, and then giving it as like an infusion to the patient to then go to the liver and make the protein you're missing, make the factor protein. There's other investigational methods being used, meaning that you can't get it unless you're on a study, where they're actually taking cells from the patient and in the lab, in like a petri dish, growing up those cells that would then have the genetic material put in them and then given back to the patient, usually with like a bone marrow transplant type of scenario. So these things are being investigated. And like I said, there's a couple different gene therapy options that are currently available.
Is that covered by insurance or no?
Great question. If it's what I meant, the second thing I mentioned, if it's in a clinical trial, all those costs and patient costs are covered by being on the study. For the gene therapy I'm about to talk about, those are commercially available. So if there was a patient that wanted to do that thought they were a good fit for that would go through the insurance company. And as you can imagine, it's very expensive. The headlines for gene therapy in the U.S. are around $2.5 to $3 million for one treatment that may or may not work. So the science, from a scientific perspective, from a patient perspective, it's exciting for the thought of potentially having a cure. But what I'm going to tell you here next is maybe a little bit less exciting. So this is looking at some of the clinical trial data for the hemophilia A, or the factor VIII gene therapy. This is from a paper that came out a few years ago in the New England Journal, looking at how patients have done over time. And we're talking about a rare disorder with limited number of patients. So 134 patients. I mean, a lot of if you hear about the different, cholesterol medicines or blood pressure medicines, those are multiple thousands of patients. But we're talking about people that are a rare patient population, rare bleeding disorders. And so some of the drugs that we use are licensed with much fewer patients, meaning that when medications come to market, there are many things that we still need to learn about as people start to use it in the population. So the factor VIII levels, you can see the bars here and kind of the heavier green bars and how low they go. This is the factor VIII activity of patients that were on the study. And you can see there's a wide variety in how their factor levels went. So these are patients that got that viral vector with the genetic material telling their liver to make more factor VIII. And universally, because you're using this virus mechanism, it can cause some inflammation. So a lot of patients have to go on steroids or other immunosuppressant things. So it's not as simple as it sounds. The kind of take-home point from this is there's a wide spectrum. We would call it the therapeutic window, or what activity we're actually getting for the medicine that we're using. So it's unpredictable. So we're asking patients, if they're going to choose this therapy, they're going to get this infusion, probably going to go on steroids or other immunosuppression for quite a long time, months or more, lots of visits to check their levels, and we can't really predict where the levels go. And also over time, the levels seem to be going down. So it doesn't seem to be like it's a durable cure for like a once in a lifetime type of a thing. But still, there is more investigations ongoing and other iterations that will be evaluated. Similarly, for hemophilia B, for factor IX deficiency, the take-home point is the durability seems to be a little bit better with factor IX, but nevertheless, there's still the issues with the immunosuppression and things like that. But kind of the cool scientific premise is that gene therapy is here. It's being used by some patients, and we'll learn more scientifically as things go on. And as you can imagine, the other questions that may come up, yes, other disorders are being looked into for gene therapy and things like that, but it's going to take time to find things that work well. So I'm going to switch gears a little bit to von Willebrand disease. And again, if there's questions, bring them up, and we'll try to go through this quickly for the sake of time. People with von Willebrand disease is the most common inherited bleeding disorder. People tend to have mucosal bleeding, so that means mucous membranes like heavy menstrual bleeding or nosebleeds or bleeding from their mouth, teeth, easy bruising, bleeding from procedures, and more severe von Willebrand disease can have bleeding into muscles and joints, like I mentioned for hemophilia. It affects up to 1% of the general population, but only 1 in 10,000 people seek care at a specialized center like ours. So there's lots of people. I mean, I would say almost every week here, probably every week or every couple of days, we're making new diagnosis of people with von Willebrand disease because it's very prevalent. People bleed, and it's not been investigated. And there are things we can do to help treat it. Most people have a deficiency, type 1, just not enough of the von Willebrand factor. And then there's variants where the von Willebrand factor doesn't work as well, doesn't bind platelets or collagen or factor VIII well. And type 3 is very severe, where there's bleeding more into muscles and joints. And there's been some diagnostic classifications updated as recently as 2021. So usually, like hemophilia, we replace that with von Willebrand factor infusion, so a medicine that we can give through the IV. We use other medicines that help to stabilize the clot that are oral, like Amicar or Lyseta. Those are medicines that we use in people with other bleeding disorders as well, help to stabilize clots, help with heavy menstrual bleeding and things like that. But I did want to touch on one of the molecules that seems to have potential in more severe von Willebrand disease, called BT200. So this is actually a subcutaneous medicine that binds to von Willebrand factor and actually helps to increase von Willebrand factor and factor VIII. In fact, there's even thoughts that this molecule could be used in combination with factor in hemophilia A, because basically this antibody that was originally designed to try to block von Willebrand factor turns out it helped the levels to go up. And so you can see here, this is some of the early studies looking at either placebo in the red here at the bottom, so meaning it's not the molecule, and then the molecule and what it did to the von Willebrand level and what it did to the factor VIII activity. So this is a subcutaneous option for people with von Willebrand disease that's currently in clinical trials that may be helpful for people who have VWD, who need to have more regular therapy, like more regular bleeding prevention, or maybe women that have very heavy menstrual bleeding, or certainly anyone with bleeding in the muscles of joints and things in that regard. So stay tuned. Very interesting molecule that's gotten a lot of buzz in the von Willebrand world. I did want to touch on iron deficiency anemia, because quite a few of our patients have this. A lot of times it's a byproduct of bleeding quite a bit. And this actually is when Dr. Tarantino said we looked under the microscope, this is what a blood smear looks like in someone that has really bad iron deficiency. Your red blood cells are supposed to look kind of more like this, kind of a circular, or we call it a biconcave disc, and the red is the hemoglobin that carries oxygen in the body. And you can see in this patient, the cells look very pale. They don't have enough hemoglobin. And in this patient in particular is due to lack of iron, which is very common. 25% worldwide incidence of some form of anemia. Half of that is iron deficiency, and there's higher incidence in the developing countries. A recent study was actually done in JAMA, the Journal of the American Medical Association, just to look at the prevalence actually in US females 12 to 21 years of age, so focusing in adolescents and young adults. This was looked at in over almost 3,500 individuals from 2003 to 2020, found that the incidence of iron deficiency was almost 40% in that age range of young females. That's just iron deficiency without anemia. If iron deficiency gets bad enough, you get anemic to where it looks like this under the microscope, and that was 6%. And then looking at some of the ferritin or iron store cutoffs, the prevalence changed based on what the definition is. Yeah.
When the kids come in for their annual,
Uh-huh.
is checking their iron levels part of their process?
Very good question. Absolutely. If they've been having bleeding concerns. So if patients come in and say, been having lots of nosebleeds, or certainly if it's, a woman that's, or a young girl that's just starting to have her periods, absolutely is something that we check. Check iron studies all the time. And usually we use certain cutoffs based on the patient's symptoms and, a lot of fatigue and symptoms like that, to decide if we need to do treatment with either oral iron pills or even giving IV iron infusions.
So if the patient is a menstruating female, you automatically do iron?
Absolutely, we check that
Okay.
very, very frequently. It is case by case basis, but it's very frequently that we do, and something certainly we encourage you to bring to our attention. Obviously, men who have bleeding disorders too can have other types of bleeding. We'll check that very commonly, but yeah, that's a common thing that we'll do. But this is just to highlight that iron deficiency is very prevalent. Quite a few of our patients have iron deficiency, whether they have a bleeding or a clotting problem. And there's a growing understanding in our field that iron deficiency needs to be treated. So yeah, go
Is that
ahead.
something you see in like a CMP, like just the regular blood work, or is that like a separate test to look at?
It's a separate test. So your CBC, or the blood count, we would see the amount of red blood cells, white blood cells, and platelets and their sizes and some indices and things like that. If you're severe enough to where you have iron deficiency anemia, we're going to see that by the hemoglobin level being low. But as you see, that's about 6%, right? So there's much more commonly that people will be iron deficient. And the thing that we need to test is that ferritin level. So it's a different test to see if you're iron deficient or not. So a lot of early iron deficiency, you actually won't yet see the cells look like this, and you won't see anemia. Sometimes the red cells start to look a little smaller as the iron deficiency gets more pronounced, but not all the time. So you have to actually test that ferritin level in that regard. Treatment's pretty straightforward, oral or intravenous, and then happy to have that to talk about that more. Just going to touch on as we're moving into kind of the clotting issues. One in particular, fibrinogen deficiency. So fibrinogen is at the end of the coagulation cascade and helps to really cross-link and make those clots nice and strong. There can be problems with how that functions. One in particular, having dysfibrinogenemia or fibrinogen that doesn't work very well, people can bleed or they can clot. And certainly we have many patients that have that as well. Unfortunately, the treatment for that is less advanced than some of the other things we've been talking about, where we still have to use blood products. There are fibrinogen concentrates that can be used that we give patients here, and also some of those medicines that help to strengthen the integrity of a clot, like I mentioned. So now we're going to close with talking about blood clots, because it's also very important. And again, just from a historical perspective, we'll touch on Rudolf Virchow, that I bring up all the time to my patients and trainees and everyone I talk with about clots. Lived in the 1800s, and it's really this understanding that we still have today about thrombosis is caused by blood not flowing well or stasis, having some type of vessel wall injury in a blood vessel, and then having things that you can't necessarily control, some you can, but not all, in how your blood clots, whether you have a genetic mutation or something that makes your blood clot too much. And this is one of the first descriptions, Virchow in 1859, where he was describing there in that quote, the development of basically a clot in the lungs. And so where he said, I've bestowed the name embolia for, for an embolism, it's pretty amazing that we still use the premise of this very smart physician from many years ago today. So again, when we're talking about how we treat individual patients' blood clots, it's a patient-centered approach, just like we've been talking all morning or afternoon now about how we treat bleeding or clotting disorders, ITP, hemophilia, vulnerable brain disease, whatever it is. And really the thought has moved from a one-fits-all model where it used to be like, we're just going to treat you for a couple months and that's it, really looking at an individual patient's approach. And now we look at, have you had recurrent events? Are there other things, autoimmune disorders like antiphospholipid syndrome or inherited things or family history? We use physical exam findings, like if you've had a clot in your legs and you have prolonged swelling in your legs, to really see what the treatment's going to be, or how long are we going to treat you. It's really a dynamic process, all the while taking into account the patient's preference and values. So it's very much so personalized medicine for people that have blood clots, as well as for people that have bleeding disorders. And just to kind of give you a spectrum, we've talked about bleeding disorder treatments. So for the clotting treatments, usually this is from a European consensus document on some of the oral agents. But usually there's some sort of initial phase where we treat you, like for some of the medicines, apixaban, which is Eliquis, or rivaroxaban, Xarelto, VKA, vitamin K antagonist, which is warfarin. And we'll have some kind of initial phase, long-term phase, and extended phase in the treatment. That can vary from patient to patient. Just, just to highlight that it's available, there are anticoagulation reversal agents. Patients a lot of times will ask me if they're going on one of the newer agents, well, what happens if I bleed? So there are protocols at all the area hospitals for emergent management of bleeding. And certainly there's different things, the PCC or prothrombin complex concentrates that are available at the local hospitals. They talk with us about how to reverse it. There are some more directed, specific reversal agents that are also used for people when needing to reverse anticoagulation, that are less commonly needed, less commonly used. And then I want to kind of close talking about some of the investigational anticoagulants. So one of the big areas that's being looked at is actually inhibiting factor 11. So factor 11, whether it's active or inactive. And on this slide are multiple different investigated molecules to look and see how to help stop or prevent clotting by neutralizing factor 11. Highlighting some of them, milvexian, looked at in about 1,200 individuals compared to compared to enoxaparin or Lovenox. Patients seem to have lower risk of clotting issues. These are small molecules that can be given, some given through the IV, some given by different routes. And just to kind of highlight that the factor 11 deficiency or causing this deficiency with a targeted small molecule may be kind of the next phase of moving into anticoagulation and helping to prevent people from clotting. In fact, one just last year, the abelacimab was looked at in atrial fibrillation or abnormal heart rhythm, and the trial was stopped early because of overwhelming reduction in bleeding compared to standard of care. So some of these may be coming on the market soon. This is just to show in clotting disorders or for anticoagulation, there's multiple different mechanisms that are being looked at. A lot of these are very early, but just to kind of put a perspective on, there's lots of different things being looked at on how to anticoagulate patients with lower risk of bleeding with still helping to prevent blood clots. So stay tuned, there'll be more to come for sure. And so with that, I know we're running a little behind on time, but happy to take any questions, or certainly you can see myself or Dr. Tarantino afterwards if you have a particular question.